Good evening, ladies and gentlemen. I'm Dr. Ahmed Wagih, an assistant lecturer of diagnostic and interventional radiology at Cairo University Hospitals. And today we will be talking about a novel technique about the transoral approach for pharyngeal venous malformations. Our agenda today will be an introduction about vascular malformations, talk about the objectives and patient selection criteria, and the investigations needed, technique, results, present some cases, and talk about some discussion points. Vascular malformations are developmental abnormalities of the vascular system. They occur during fetal development but could present at various ages. They could include arteries, veins, or lymphatics. The vessels enlarge and create tangles, pockets, and shunts of which abnormal blood flow occurs. The earliest method for classification of these malformations was by Virchow in 1863. They were divided into angiomas and lymphangiomas. And then by Mulliken and Wagih in 1982, on the basis of cell kinetics, they were divided into hemangiomas and vascular malformations. And this was further divided in 1996 by the International Society for the Study of Vascular Anomalies, or ISVA. They were divided into vascular tumors, benign and intermediate tumors, and then into vascular malformations, of which some are slow flow and some are high flow. Our focus today will be on venous malformations, as it is the predominant pathology in our sample. Venous malformations are the most common type of vascular malformation encountered in clinical practice. They are benign lesions composed of cluster of ectatic low-flow endothelial-lined venous channels. The overall frequency is 1 in 10,000 cases, and it might be associated with familial or syndromic patterns. Venous malformations have poorly formed walls with less muscle development, and while they are congenital, they don't always have to show up at birth and then can present later in life. They tend to generally enlarge over time due to the weakness of the walls of the veins, and they have a rare incidence of spontaneous involution. Puig classification in 2003 divided them into type 1. Type 1 has negligible venous outflow to normal venous circulation. Type 2 has a normal venous outflow with normal veins to the general circulation. And then type 3 has abnormally dilated and tortuous venous outflow. And type 4, there isn't a discrete focal mass. There is dilated and tortuous abnormally functioning venous structures. In the head and neck specifically, vascular malformations can pose significant challenges due to their tendency to affect deeper structures such as the parapharyngeal space, muscles, retroorbital space, and bone. They can lead to complications such as dysphagia, obstructive sleep apnea, airway obstruction, and proptosis. And then also episodic thrombosis might arise within the vascular malformation, leading to severe discomfort, edema, and pain. The formal resection of venous malformations is very complex and potentially risky surgical task with a very high rate of recurrence. Our objectives in the study was to investigate the size reduction and symptomatic improvement in patients with pharyngeal venous malformation post bleomycin sclerotherapy, to assess the control of bleeding attacks caused by venous malformations, and to assess the success of weaning off tracheostomy if performed. Our patient selection criteria: it was done on 14 patients, 3 females and 11 males, and their ages were ranging between 3 and 54 years. The inclusion criteria was any patient that had functional symptoms due to the presence of a venous malformation in the parapharyngeal space, regardless of other extensions in the head and neck. Our contraindications or exclusion criteria were contraindications to general anesthesia, severe allergy to the sclerotherapy agent, and patients that were diagnosed with high-flow vascular malformations. Informed consent, of course, was obtained from all the patients, and details of the procedure and potential complications were discussed. We did some investigations, starting with the clinical examination. A full medical history was taken from patients, including the age, gender, onset, course, and duration of the complaints, associated pain, any cosmetic disfigurement, and congenital anomalies and positive family history if it was relevant. Inspection was also done for the swellings, for scars, or any bluish discoloration of the skin, and any aggravation caused by Valsalva maneuver, and then palpation done to examine the painful regions for tenderness. We also did a contrast-enhanced MRI This was the main radiological examination. It delineated the size, relation, extensions, and signal properties of the venous malformation, and it also served as a baseline reference for evaluating treatment response. The collected data were the maximum dimensions of all the lesions in the anteroposterior, transverse, and craniocaudal dimensions, as well as the volume by multiplying all of the dimensions and dividing by 2. This is measured in cubic centimeters. And we also saw reduction of signal on the STER and T2 and contrast uptake in the follow-up studies. We also did a CT angiography of the neck. This was done to exclude any underlying high-flow AVM. We also did an ultrasound and Doppler study for superficial lesions that communicated with the pharyngeal portion. And we used a linear high-frequency probe. Our technique, first of all, we do some patient preparation, overnight admission into the ENT ward for monitoring of vital signs and blood work for anesthesia, fasting for 6 hours after a light dinner, and then we transfer the patient the next day to the interventional radiology unit. Dexamethasone is always administered during induction to prevent edema and swelling post-procedurally, and then a Boyles-Davis retractor is inserted to maximally open the patient's mouth, and the retractor is then supported on Drafen rods and the patient's neck is extended. The endotracheal tube is secured on the side contralateral to the lesion, and then we adjust the overhead light in order to aid better visualization of the lesion. And then under direct visualization, the malformation is punctured using a 22 to 25 gauge spinal needle. We always check for blood reflux and inspect the reflux within the syringe or the spinal needle. And then we do a digital subtraction phlebography via injecting contrast material under fluoroscopic guidance for visualization of the vascular tree of the venous malformation and identification of any unfavorable draining veins. This is a X-ray image confirming the position of the needle where the arrow is. And this is a injection of contrast media under fluoroscopic guidance in order to visualize the venous malformation and its outflow. In this case, it was a type 1. And then bleomycin is prepared on site by adding 7 milliliter of saline on its powder form, and then dividing the mixture over smaller syringes and injecting it under fluoroscopic guidance. And then any unfavorable draining veins were managed by direct compression, and the needles were then removed, and hemostasis was achieved using adrenaline-soaked gauze. Patients are then extubated and transferred to the ENT ward, where they receive additional dexamethasone, good intravenous hydration to reduce the swelling. They also receive appropriate sedatives. There's regular monitoring of the airway patency, and the ENT team was always on alert for any need for urgent tracheostomy. And after 24 to 48 hours, the patients are then discharged and advised on their follow-up schedule and medications. Follow-up, we do a new MRI examination after 45 days for comparing pre- and post-treatment lesion volume and maximum dimensions, ENT assessment of the lesions by direct visualization, and then we also we take a patient satisfaction survey focusing on the improvement of each major symptom, whether it was pain, dyspnea, choking, etc. And the survey grades the response from 0 to 10, where 0 implies no improvement whatsoever, and 10 implies total resolution of the symptoms. Majority of our symptoms were throat pain, dyspnea, choking, sleep apnea, dysphagia, headache, bleeding, and some unique symptoms on a case-by-case basis, which was bluish discoloration of the skin, excessive snoring, urinary incontinence associated with sleep apnea, sloughing of necrotic tissue in the throat, and occasional cyanosis and sleep difficulties, and exercise limitation. On correlating our post and pre-treatment volumes and maximum dimensions, there was a highly significant reduction in the volume and maximum dimensions post-treatment, as well as a very significant reduction of all the patient's symptoms except headache, which is a general symptom. Now we present some of the cases. Case 1, it was a 3-year-old male patient, exhibited dyspnea, dysphagia, episodes of choking, and then ENT examination revealed a vascular lesion within the pharynx, which was encroaching upon the airway. This is the pre-procedural MRI. It showed a cystic creeping transspatial VM of the left oro and hypopharynx. The lesion also exhibited high STER and T2 signals with delayed contrast enhancement. This patient received 2 sessions of bleomycin therapy, And the last follow-up showed 99% reduction in the MRI volume, reduction and heterogeneity of the T2 and stir signals, decreased contrast enhancement, and total resolution of all patient symptoms. And this is the post-procedural MRI. These are the dimensions pre and post-treatment. We can see there is a significant reduction in the maximum dimension and the volume. And this is a comparison between pre and post imaging. Case number 2. This was a 30-year-old male patient who exhibited throat pain, dyspnea, episodes of choking, excessive snoring, sleep apnea, and dysphagia. The ENT examination also revealed a vascular lesion extending extensively within the pharynx with significant airway compromise. As you can see, the lesion here is quite big. MRI showed an ill-defined lobulated creeping transspatial venous malformation of the left naso, oro, and hypopharynx. The lesion exhibited high T2 and stir signals with delay contrast enhancement, and we had to do a pre-treatment tracheostomy for the severity and extensivity of the lesion. This patient received 5 sessions of bleomycin sclerotherapy. On the last MRI follow-up, we saw a 35% reduction in MRI volume. There was also a reduction in heterogeneity of the T2 and stir signals, decreased contrast enhancement, total resolution of most symptoms with significant improvement of dyspnea, which was graded 8 out of 10. This is the post-procedure MRI. Here we can see the post-procedure volume. There was a reduction from 93 cc to 60 cc. Some residual snoring remained, and the tracheostomy was successfully closed. This is a comparison between the pre and post imaging. Our last case is a 30-year-old male patient that exhibited attacks of severe dyspnea, choking, and dysphagia, and also the ENT examination revealed a substantial vascular lesion extending extensively within the pharynx with significant airway compromise. Here's the pre-procedural MRI imaging. It showed an ill-defined lobulated creeping transspatial venous malformation in the left oro and hypopharynx. It exhibited high T2 and stir signals with delayed contrast enhancement, and also this patient had to undergo a tracheostomy before the beginning of treatment due to the extensivity of the lesion. This patient received 7 sessions of bleomycin sclerotherapy with 57% reduction in MRI volume on follow-up study, reduction in heterogeneity of T2 and stir signals with decreased contrast enhancement, and total resolution of dysphagia. And during the ENT examination, he showed significant improvement in dyspnea and choking attacks. This is the post-procedural MRI imaging. These are the calculations. There was a reduction from 83 to 35 cc in volume, and currently there are attempts to wean off the tracheostomy. This is the pre-imaging and post-imaging of this patient. We aim to clarify the efficacy and novelty of the minimally invasive interventional radiology procedure, presenting a safer option than surgical resection, and our study is one of the largest prospective case series to focus on the successful treatment of venous malformations specifically located within the pharyngeal spaces and solely using bleomycin as a sclerosing agent. When it comes to radiological improvement, there was an overall reduction in volumes, about 44%, and an overall reduction in maximum dimensions of the lesions, about 17%, as well as reduction in stir signal and T2 signal and contrast enhancement in all of the cases during the follow-up studies. According to clinical improvement from the surveys we distributed upon the patients, there was a statistically significant improvement in almost all the documented pre-treatment symptoms. Bleeding attacks exhibited by patients showed 100% complete resolution, and the rest of the symptoms showed an overall reduction between 73 and 88%. As for the need for tracheostomy, only 2 of our patients out of 14 had undergone a prophylactic tracheostomy before beginning the treatment. The tracheostomy was successfully closed in one of the patients after significant improvement of the symptoms, and the other patient is currently undergoing attempts for weaning of the tracheostomy. About adverse events, all of the events were peri-procedural. There were no significant morbidities or complications seen after the recovery period. It was just some post-procedural bleeding attack that was promptly controlled. There was choking upon reversal of anesthesia, which is a normal event. Sometimes it happens. Post-procedural severe dyspnea and mild skin redness. About recurrence, there was only one case of recurrence. This was a 25-year-old female with a large oropharyngeal venous malformation, and she complained of dyspnea, dysphagia, sleep apnea, cyanosis, and bleeding attacks. And after 5 sessions, there was reduction about 53% of the volume with significant improvement of all of her symptoms. However, the patient got pregnant shortly after the treatment and experienced a moderate recurrent of dyspnea, dysphagia, and sleeping difficulties. However, she is currently able to tolerate her symptoms and refused to undergo any further imaging until her due date. And the mean number of sessions in our study was about 4 sessions, with the median being 4 and the maximum number being 7. Bleomycin is highly recommended as a sclerosing agent as it is safe, shows significant results, and has a high success rate. And while ethanol could sometimes offer a convenient and low-cost and more potent treatment, it is still associated with higher rates of complications compared to bleomycin that could be safely used in lesions related to the airway or the orbits. And to summarize, similar studies achieved less comparable results with 3% sodium tetradecyl sulfate or 3% polydocanol. However, there is a lack of specific evidence to ascertain which sclerosant agent is ultimately superior in terms of therapeutic effects. The choice and interchangeability of these sclerosants should always be tailored on a case-by-case basis according to the safety, the potential adverse effects, and the patient tolerance. And in conclusion, this is one of the largest prospective case series studies to confirm that bleomycin is both safe and effective for treating venous malformations in the pharyngeal spaces, with significant reduction of venous malformations volume and maximum dimension, significant improvement of symptoms, and without long-term morbidities or complications. And finally, collaboration with ENT surgeons is very essential to tailor a case-by-case approach for venous malformations, as it is an integral component of successful treatment. Thank you so much.